Hi, everyone. I'm Enrico Escher, and one of my duties as the Executive Director of the Frank J. Veith International Society is to open this excellent webinar entitled the Carotid Summit. At the onset, let me please recognize the work done by our current president, Dr. Peter Klobitsky, who helped put this webinar together and who will moderate it with Dr. Audra Duncan. Dr. Klobitsky is the Joe M. and Ruth Roberts Chair Emeritus of the Division of Vascular and Endovascular Surgery at the Mayo Clinic at Rochester and Scottsdale, Arizona. Dr. Duncan is currently a professor of surgery and chair of vascular surgery at Western University in London, Ontario, Canada. Thank you both for your efforts and expertise. Just by reading the names of the speakers and discussants who are participating in this session, you will immediately recognize the prominence of it. We were fortunate to gather this superb group of internationally recognized experts in carotid diseases. Each of them will be properly introduced by our moderators. Equally important is to recognize the man that motivated the creation of this society. We're honored to have Dr. Veith with us today, and I'm sure he will, as usual, come up with interesting and thought-provoking questions. If by any chance you miss portion of these webinars, don't worry. You'll be able to access it at www.veithsymposium.org later on this afternoon. Also, a summary of this webinar we publish at the upcoming monthly issue of the Veith Symposium Bulletin. This bulletin is sent to 17,600 vascular specialists worldwide. Without further delays, I would like to invite Dr. Klobitsky for his comments. Peter?
I'm Peter Klobitsky from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery. I am really honored this year to serve as president of this great organization named after Dr. Frank Veith. In the United States, each year, close to 800,000 people have new or recurrent strokes, and 87% of these are ischemic. An estimated 130,000 interventions are performed here annually to treat lesions in the carotid bifurcation with endarterectomy, transfemoral or transcarotid artery stenting. As Dr. Escher mentioned, we are extremely grateful that an outstanding international faculty accepted our invitation to participate in this as critical issues affecting our patients with carotid disease. Today, we will learn about the latest advances in medical and interventional treatment of asymptomatic and symptomatic disease on the effect of carotid intervention on cognitive function. So without further ado, I give the word to my co-moderator, Dr. Audra Duncan, Professor of Surgery and Chair of Vascular Surgery at Western University in London, Ontario, Canada, to introduce our first speaker. Audra?
Thank you, Peter and Enrico. We'll start off with the topic of asymptomatic carotid stenosis and medical treatment of asymptomatic carotid stenosis. And I'm really pleased to present Dr. Thomas Brott, Professor of Neurology at Mayo Clinic College of Medicine in Jacksonville, Florida, to discuss that.
Thanks, Audra. Are you able to see my screen okay?
No, we're not.
Not yet.
You need to click on the share screen button on the bottom.
How's that?
Yes.
Well, it's first of all, a delight to be here. Thanks to Dr. Escher, Dr. Klobitsky, and Dr. Duncan. Talking about best medical treatment, I thought I'd cover both because these patients come into our office. And let's see here. And I have no disclosures. This is what we all want to prevent. However, the patients who come to our office with carotid disease more often will have lacunar stroke down the road than carotid stroke. So we have to keep that in mind. And of course, think of the entire patient. And of those, you can see that only about 17% of patients are from large artery stroke. So our 70-year-old patients who come in with carotid stenosis, we really have to think of the entire patient. So we're going to talk about guidelines from the American Heart Association, but there's a lot of overlap with the guidelines from other regions. Keep in mind that prevention is not Tom Cruise and Top Gun in an aircraft carrier takeoff in a jet. If we're successful with prevention, nothing happens. Not so exciting. So level A recommendations mean that there are 2 randomized trials or 1 randomized trial and a meta-analysis that show that that particular treatment is effective. And there are a large host of treatments that are level A, and you can see them come up on your screen. Reduction of alcohol in heavy drinkers, anticoagulation. And these, of course, are people coming in who are asymptomatic. But we see patients who come in with TIA and minor stroke. And here, again, the level A recommendations, 2 randomized trials. Now we want to lower LDL to less than 70, hemoglobin A1C lower than less than 7, antiplatelet therapy for non-cardioembolic stroke or TIA, ASA clopidogrel or ASA plus tipiritamol for non-cardioembolic stroke. And for minor stroke, within the first 90 days, this combination, ASA and clopidogrel, and then single antiplatelet therapy thereafter. In CREST-2, and we recommend for the listeners or the participants in this webinar that we be more aggressive with our patients. In CREST-2, where we have asymptomatic patients, we're modeled after the Sampras trial, where the intensive medical therapy worked very well in patients with intracranial stenosis. And in fact, the results for medical therapy were superior to that for stenting. Now, this is stenting carried out about 10 to 15 years ago. Things are different today. But the medical therapy stands, we think, the test of time. So what is the medical management that we recommend and use in CREST-2? Well, aspirin, primary risk factors, oversee the management of secondary risk factors, and we use a lifestyle program, which may or may not be available to your own patients. So let's look at our key risk factors. In CREST-2, we go after the blood pressure. We want the blood pressure less than 130. And our view is that it needs to be cookbook. The best medical centers across the United States are not achieving effective treatment of blood pressure, which you'll see in a moment. So we keep seeing the patient until we can get the blood pressure under 130. Then LDL cholesterol. Again, we're now aiming for less than 70. We see the patients every 44 days. We have a cookbook, just like for blood pressure. And really, that's important. Why is it important? Well, these are patients. We now have over 2,000 patients in CREST-2. They're from the best medical centers. And here's how they were at baseline. Systolic blood pressure less than 130, only 42% from the best medical centers. LDL less than 70. These are patients who are known to have asymptomatic carotid stenosis. That's severe. So our usual way of treating patients is not that effective. And you can see how well we're doing in CREST-2 with this cookbook, protocol-driven, target-driven approach to medical therapy. For patients who are statin intolerant, or for patients who you can't reach goal, consider the PCSK9 inhibitors, alirocumab, evolocumab. We were able to get alirocumab for nothing for Regeneron, and you can see here are the averages in our 100+ patients on alirocumab, and these lines are individual patients. And look how effective these PCSK9 agents can be. And now on the horizon is an mRNA inhibitor called inclisiran, which is just approved by the FDA for treatment of our patients. So in conclusion, in 2021, starting medication alone is not enough, as I showed you with those baseline results. Treating to targets is needed. A cookbook, protocol-driven approach for your own patients so that they get frequent follow-up. All patients with carotid stenosis should be treated to systolic blood pressure less than 130 and LDL less than 70. All patients with carotid stenosis should quit smoking and get moving. And in the Sampras trial, physical exercise was particularly effective in the medical group. So prevention, it's not acute treatment for stroke. You don't hear a lot of music in the background because nothing happens. But my final conclusion is when it comes to prevention, nothing is good. Thanks very much for your attention.
Thank you, Dr. Brott. And now for our discussant, it's really a man who needs no introduction, but we'll introduce him anyway. It's Dr. Veith, professor of surgery from the Cleveland Clinic and from NYU, and he's going to discuss his burning question of Dr. Brott's presentation.
Yeah, Tom, I mean, as usual, that was a very excellent talk. I guess my burning question, and I think we'll be talking more about it, let's assume that you can treat somebody well medically, that you have a cooperative patient, say like me, and I have a carotid stenosis, say a high-grade carotid stenosis. Do you think it's possible that, or even probable, that medical treatment for asymptomatic carotid stenosis will be equal to or better than interventional treatment with either CEA or CAS? And as an adjunct to that burning question, I have a second sort of secondary question. What if you can get the LDL down to 40 or less than 40, as I think will be possible with some of the newer drugs that you mentioned? Do you think that will be even better? And again, the burning question, do you think medical therapy will be equal to or superior to interventional therapy?
Frank, I know how evidence-driven you are. And as PI of the CREST-2 trial, I would ask everybody to enroll some patients to get the evidence-driven answer, because at this point, I don't know the answer. I would say that the hypothesis that the medical people could have would be that not only could aggressive medical therapy arrest carotid plaque development, but perhaps it might even lead to regression. Glagoff et al., looking at coronary artery plaque, were able in a randomized trial to show plaque arrest and plaque regression in the patients who were on the very aggressive LDL therapy that you alluded to. So I think your first question is still open, not certain of the answer. The second question, I think, with more aggressive therapy, that alirocumab group, Frank, was at 55.
Right.
And there is evidence to indicate in animals and in clinical studies that driving it below 55 might be better in terms of arresting plaque and even causing regression of plaque. The big question, of course, is in the medical patients after 1 year, 2 years, 3 years, they haven't had revascularization. How will they do later on?
So it's still an open question. That's
Yes.
the important
Yes.
thing. Okay.
Thank you very much, Dr. Brott and Dr. Veith. The next presentation is on treatment of asymptomatic carotid stenosis with endarterectomy and stenting. And we are pleased to have Dr. Alison Holliday, who is the principal investigator of the ACST2 trial that was published last year. She is Emeritus Professor of Surgery at University of Oxford and the past president of the European Society for Vascular Surgery. Alison?
Thank you very much indeed, and thank you. And it's very good to see everybody here and to say hello to Frank, and thank you for an invitation. It's an honor to be here. I have no closures, so I will try to move on to the next slide, which is not actually happening. There we are. So I would like to describe these two treatments in terms of the trial that we've just completed called ACST2. And we looked at 3,625 patients who were randomly assigned to one of these two treatments for tight carotid stenosis. The background to this is that we know that surgery restores patency, and trials show that it approximately halves later stroke rates. Modern medical therapy may well do more than that, but at least we know it also halves long-term stroke rates. Well, stenting also restores patency. And in a recent nationwide registry data, both these procedures have about a 1% risk of causing disabling stroke or death. And here you can see the large nationwide German registry with 18,000 stents and 86,000 endarterectomies. And you see the disabling stroke or death rate as an inpatient is about 0.7%, but at 30 days is about 1%. So we need randomized evidence because although the registries can assess procedural hazards, they cannot reliably compare long-term non-procedural stroke rates. And that's what we need randomized evidence for. And ACST2 is a trial in 130, mostly European hospitals, each with a collaborating vascular surgeon, interventionist, and stroke doctor. They were advised to use normal procedures for them, which for stenting were any CE-approved devices and double antiplatelet therapy. Patients had to have a severe carotid artery stenosis of at least 60% on ultrasound with no recent ipsilateral stroke or other symptoms from it. Most importantly, they had to be thought to need a carotid procedure, either stenting or surgery, and they had to be suitable for both. And there had to be substantial uncertainty whether to prefer one procedure over another before they were randomized. So half were randomized to stenting and half to surgery. They both got good long-term medical treatment with 80 to 90% having lipid-lowering antithrombotic and antihypertensive therapy. And this trial is still going on, so we will be looking at that to 10 years. The strokes were classified 6 months afterwards, with a disabling stroke being classified as a modified Rankin scale score of 3 to 5. So here you see the 5-year risk of procedural death or of serious disability. On the left-hand side, you see there is a 1% procedural risk from both procedures, similar, in fact, to the registry. But if you take out the procedural risk and look at the right-hand side, you'll see the long-term stroke rate ratio for serious strokes in these patients. And it is the same for stenting and surgery, 2.5% at 5 years, 0.5% per year. Then if we look at the severity of the worst procedural event and the worst non-procedural stroke, so procedural events are shown here, 1,800 stents, 1,814 endarterectomies. I've already described the disabling and fatal strokes, and they are the same before and after the procedure. For non-disabling ones in stenting, there was 48, a 2.7% procedural risk versus 1.6 for endarterectomy. And later, after the procedural events, it was 2.7% for stents versus 1.9%. These are non-disabling, so I want to look in some more detail at this. And you'll see that if we break these down into modified Rankin scale score of 2, 1, and 0, 2, they are about the same. At 1, 23 versus 15 procedural, 23 versus 17 non-procedural, and for a modified Rankin scale score of 0, 16 versus 5, and 15 versus 12. So we see that these are the areas where the difference is concentrated. And if we look at any procedural stroke, death, or any stroke by severity, we can see that for a modified Rankin scale score of greater than 1, in other words, fatal, disabling, or unable to carry out some previously usual activities, the events are 77 versus 77. For 0 to 1, non-disabling and still able to carry out all previously usual activities, it's 77 versus 49. So this is where the difference lies. So the summary of these results is that there's a 1% 30-day risk of procedural death or disabling stroke, a 2.5% 5-year risk of the non-procedural disabling or fatal stroke, But with stenting, there's a 1 to 2% excess risk of non-disabling stroke that left patients still able to carry out all their previously usual activities. So we see the procedural events agree with that registry that I showed you earlier. And to compare the effects for non-procedural ones, we need to consider all the trials. No symptoms at the top, ACST, and the symptoms in the last 6 months, these 4 here. And for all of these, the comparison between surgery and stenting is non-significant, and with a p-value of 0.21 and a rate ratio of 1.11. So this is similar for ipsilateral strokes and for other strokes. In summary, competent CEA and CIS involve about a 1% risk of procedural death or disabling stroke, then have similar effects on long-term rates. For asymptomatic patients, we've seen that even with good medical treatment, CEA will halve the long-term stroke rate. And the punchline, if so, then in ACST2, where 0.5% had a fatal or disabling stroke with either of these procedures, if they had had neither procedure, then about 1% per year would have had a fatal or disabling stroke. I'd like to stop there and thank you for your attention.
Thank you very much, Dr. Holliday. This was indeed a landmark study. And Dr. Hans-Henning Eckstein, who is a professor of the Technical University of Munich, head of the Department of Vascular and Endovascular Surgery, Klinikum Rechts der Isar in Munich, Germany, is going to have a burning question. Henning.
Thank you, Peter, and thanks Enrico and Frank for inviting me. And Alison, as always, a great talk, a summary of a huge clinical trial. Congratulations to that. I have a questions also with respect to the issue of minor strokes or non-disabling strokes, as you mentioned. You said that the assessment of the severity of cerebral ischemia was done 6 months after it happened. So does that mean that people, for example, with a minor stroke at day 30, but improved until day 180, were assessed as ranking 1 or ranking 0? Or does it also mean that the suffering from minor stroke over months may be a little bit under-assessed?
Well, of course, we only have these 2 points of assessment. So there's the 30-day point, and we can look at those. And obviously, as everybody knows, it's quite common for people to have an early stroke, let's say in the first few days, and then find that the modified Rankin scale is actually quite a lot less, maybe goes from 4 to 2, 4 to 3 as time goes on. With 0 and 1, I think we didn't have people really going from 0 to 1. We had people going from 1 to 0, and occasionally from 2 to 1 and to hardly ever to 0. But really, it's the small difference that occurs over that time that we just looked at, those 2 points. I don't really know whether that answers your question, because obviously we don't see the patients in between. But we do get some idea then as we follow them annually of whether they have any further strokes or whether they have assessed themselves as having any residual disability. And that is of some interest, and we'll be looking at that in the future.
Well, I would say if we have a 30-day endpoint, patients should be assessed at 30 days rather than after 6 months. So this is a field of insecurity about the data. I mean, also in the registries that you mentioned, we have the event within the first days, and they are of course collected and
yes,
within the data. So we don't have time to look whether patients improve, yes or no. But that's a difference, I think.
Yes, yes, and it's, I mean, it's an ideal situation, isn't it? Whereas in reality, and this is a very practical, everyday type practice that we're looking at, people have different points during that 30 days where their stroke physician or neurologist comes along to give that assessment.
Peter, could I make one quick comment or save it for the end?
Later.
I think we'll have a really spirited panel session at the end. There's already a lot to discuss. We're going to move on from asymptomatic to symptomatic disease to discuss early intervention for symptomatic carotid disease. Ross Naylor, from a professor of surgery from Leicester Vascular Institute and professor of vascular surgery at Glenfield Hospital in Leicester, United Kingdom, will discuss this.
Thank you very much, Audra. Thank you, everyone. It's a pleasure to be with you again. I have no disclosures relating to this talk. About 15, 16 years ago, the American Heart basically recommended that if you operated on patients with TIA or ischemic stroke within 6 months, you were offering an appropriate service. And this probably introduced a level of complacency about there being no need for urgency in this, particularly when some published studies had suggested that if you intervene early, you might have higher procedural risks. But a wake-up call was rapidly approaching. And that's summarized in these 3 studies on this slide. On the top left, Rothwell showed, looking at the timing of 549 strokes after the index TIA, that 43% occurred within the first 7 days of the TIA onset. And then in the top right, this is looking at the incidence of stroke after a TIA in patients with a 50 to 99% ipsilateral stenosis at these differing time periods. And you'll see that the stroke rates that were occurring were way higher than we had ever been taught at medical school. Bottom left, the third piece of evidence was the meta-analysis of the pooled ECST and NASIT data, which showed that the earlier you operated, the more strokes you prevented, particularly in patients with severe stenoses. And this led to recognition that the time window for performing carotid endarterectomy was very short, as we had to catch these patients while they still had all this fresh thrombus sitting on their plaque before it embolized. And as a consequence, all international guidelines on the left recommend that surgery should be performed within 14 days of symptom onset. The most recent German, Austrian, and SVS guidelines recommend against intervening in the first 48 hours. And this is largely driven, if you look on the top right, by the 11.5% death and stroke rate that was observed during endarterectomy performed within 2 days of symptom onset. But as you can see, the larger UK and German registries did not find such a high complication rate. But in reality, it's probably a moot point, because hardly anyone undergoes surgery within 2 days of symptom onset. If we look at the risks associated between endarterectomy and transfemoral carotid stenting, this is a meta-analysis of EVA 3S, SPACE, and ICSS, but similar data was found when CREST was added. And you can see here that early interventions were associated with significantly higher death and stroke rates for transfemoral CAS versus endarterectomy. Now, there have been no randomized trials with TCAR in terms of early interventions, and there's only one published registry on outcomes stratified for delay in symptomatic patients. And these results are quite commendable, but there are a number of issues. These are in-hospital events, and about another 25% of events can be added to that. And also, this registry is not consecutive. About a quarter of the patients did not have qualifying data that were allowed to be analyzed, so that more corroborative data is required for TCAR, and this is really important for the future. But it's not just the carotid intervention that's important in the early time period, and Tom Brott alluded to this. This is a meta-analysis of 3 randomized trials, excluding candidates for carotid endarterectomy, where patients were randomized if they had a high-risk TIA or minor ischemic stroke to aspirin or clopidogrel within 24 hours versus aspirin alone. And what they showed was there was a significant reduction in non-fatal any stroke, non-fatal ischemic stroke, but at the cost of a very slightly increased but significant increase in moderate to major extracranial bleeding. But there was a very interesting fact here. In the aspirinated patients, most of the recurrent strokes happened within 10 days, whereas the bleeding complications were linearly happening across the 90-day period of study. So if you limit combination therapy to 21 days after symptom onset, you would significantly reduce early recurrent stroke whilst minimizing major bleeding complications. But this obviously has implications for how we plan endarterectomy in these patients. Now on the left, you'll see there are 7 national guidelines now that recommend that aspirin and clopidogrel should be prescribed as soon as possible after onset of high-risk ischemic TIA or minor ischemic stroke. But this has not been matched by clarity about how you manage antiplatelet therapy in symptomatic patients undergoing endarterectomy. I can't tell you the ESVS recommendations because it's going to be published in 2 months' time, but the German-Austrian guidelines recommend combination therapy between symptom onset and endarterectomy to prevent early recurrent stroke and also to prevent perioperative stroke. Now, the SVS, while advising that it should be prescribed immediately after onset of symptoms, then advised an individualized approach in patients undergoing endarterectomy. Now, this is important because when you combine the intervening early and the effect of dual antiplatelet therapy, here are 6 studies over the last 9 years which are publishing reduced rates of recurrent stroke in the early time period after onset of symptoms, largely attributed to early prescribing of dual antiplatelet therapy. And something interesting happened during the recent COVID pandemic, and this is the cover study in papers in the Annals of Surgery and the BJS. And what they did was look at practices during the COVID pandemic. Data from 249 vascular units in 53 countries. And in the subsection on carotid disease, 18% only performed interventions in patients with crescendo TIAs, 43% on an individual case-by-case basis, while only a third reported no change in practice. Now, what was not reported in this trial, but data was given to me by Thanos Saratsis, is that there were 34 acutely symptomatic patients who met criteria for endarterectomy stenting, but who did not undergo either. They were all prescribed aspirin and clopidogrel. And at 12 months, 1 was lost to follow-up, 1 died of cancer, but none of them suffered a stroke. So all of this now is starting to bring even more knowledge, creating more questions than answers about the optimal treatment of symptomatic patients in the early time period. And I can tell you that the increasing evidence that the risk of recurrent stroke is reducing with modern medical therapy in the early time period has led to one major grant application going on in the UK, which is going through the review process now to effectively repeat ECST and NACIT. And on that provocative note, I will stop this and move back to the panel.
Thank you very much, Professor Naylor. I'd like to introduce our discussant, Karen Rockman, the Florence and Joseph Furtado Professor of Surgery at NYU Langone School of Medicine and the Program Director in Vascular Surgery at NYU as well.
Thank you very much. Thank you, Dr. Asher, and to Dr. Veith for the opportunity to participate in this wonderful panel today. Thank you, Dr. Naylor, for an excellent talk and summary of the voluminous evidence on this topic. And you might be surprised to hear I agree with almost everything you've said today. My burning question would be this, particularly in light of what you just told us, that it's certainly conceivable that modern medical therapy is reducing that early stroke risk in symptomatic patients. Do you think there should be any patients who have had a completed stroke that should have intervention within 48 hours at this point? And a corollary to this was, who would the patients be that you would still like to delay slightly even past that 14-day time period? Thank you again for the opportunity.
Thanks, Karen. Well, the second question is easier. Anybody who's had a disabling stroke and or who has, that's Rankin grade 3 or above, or who have an area of infarction greater than a third of the middle cerebral territory, I would defer surgery in those patients for as long as it takes them to become neurologically improved, and then consider them on an individual basis. as you know, I was very much a proponent of very urgent intervention. But when our group started dual antiplatelet therapy in the TIA clinic in the 48 to 72 hour period before we got them into theatre, we virtually abolished recurrent TIA and stroke in that intervening period. And one of the great things was it meant that we had more time to get the patients ready. So no, I don't bust a gut to try and operate within 48 hours in the knowledge that the dual antiplatelet therapy is preventing early recurrent events. But the extension of that is, how long can you then leave it? Because the evidence would suggest that the risk of stroke is actually much less than in the randomized trials 20 or 30 years ago. And this is what's driving the renewed interest in the relevance in the modern era.
Thank you.
Thank you very much, Professor Naylor and Professor Rockman. Transcarotid artery stenting is a new tool in our armamentarium, and we are eager to find out if in 2022 TCAR is equivalent with carotid endarterectomy. The speaker is Mahmoud Malas, Professor of Surgery and Epidemiology from the University of California, San Diego, Chief of Vascular Surgery at the same university there. Professor Malas.
Always forget to turn the mute off. Thank you so much for having me. Really honored to be among this elite group of presenters. I have no financial disclosures, but I'll just list the clinical trials that I participated and led at my institution and also nationally and internationally. I like to acknowledge my research team, very proud of them. A lot of young women and men who are doing a phenomenal job, really truly representation from all over the world. And I know this is an international society. Carotid endarterectomy is probably one of the most favored operations for many vascular surgeons. We perfected it over now 70 years. Still, most of us do it under local anesthetic, under general anesthesia. There's a small risk of MI and stroke, but it's not negligible. We have cranial nerve injury about 6%. 2 out of the 6% really do not resolve at 6 months. Transfemoral stenting was introduced as a minimally invasive procedure to minimize the complication, but it failed to show equivalent to CEA, and at least up to date with all the randomized clinical trial you see here, a meta-analysis of the 3 symptomatic European trials, 50% increased risk of stroke.
We cannot hear you, Mahmoud.
Memo, did you get muted again?
No, I think he lost the connection completely because we don't have his visual either. Okay, we'll wait just 30 seconds and then we'll move on to the next speaker and then he can finish later.
That's right. Okay, let's wait 30 seconds.
Yeah. Let me just work on.
Why don't we go ahead, Enrico, with the next?
I'm back.
He just got back on.
Oh, you are here. Wonderful.
So what's the conclusion now, Malas?
Yeah. So thanks, Enrico. So essentially, we know that it's the arch and getting the filter through. Now we put going through the carotid directly, avoiding the arch altogether, and establishing a flow reversal by clamping the common carotid artery. Essentially, we are doing a CEA-like protection by clamping the carotid artery. Here's a proof of concept that you see with TCD, a lot less event happening with the TCAR compared to transfemoral, similar to CEA. And with the proof study, the incidence of DWI is in par with CEA and a lot less than transfemoral. The technique's been described, and I don't want to go through it, but the procedure can be done a lot shorter time than CEA. The clamp time is 1/3 that of CEA. And it's not all about avoiding the arch. In this study, we compare a TCAR to a transcarotid stenting with distal embolic protection, and the stroke and death rate was 10-fold increase if you just do distal embolic protection versus the flow reversal. Ballooning, we said don't balloon stent in the past because of increased risk of stroke and death. Apparently, that's just only for transfemoral, not for TCAR. And this is one of the earlier study that we did comparing TCAR to transfemoral with twice as many stroke and TIA. More larger study that recently published in JAMA, it shows 50% reductions in stroke and death with a TCAR compared to transfemoral. So how about a comparison to CEA? This is a propensity score matching, 3,700 pairs. Very similar stroke and death as you can see up here, but 60% reduction in MI and about 80% reduction in the risk of cranial nerve injury. Short of doing randomized trial, we do the meta-analysis here, and you'll see very similar outcome for stroke and death, but again, an advantage with cranial nerve injury. So this is great. This is post-operative outcome. What happened at 1 year? There's 95% stroke-free survival from the Roster long-term registry. We did an analysis of the Medicare data linked to Vascular Quality Initiative, and we saw very similar stroke and death here, as you can see, TCAR and CEA. At 1 year, a lot more with transfemoral, and that outcome persisted when we stratified by symptomatic status. Now, leave it on a couple of notes. You know, age, we know it's high risk for transfemoral stenting, not for CEA. We saw that this is also with TCAR. It acted just as good as CEA with different time age, even in octogenarian. Restenosis, TCAR did better than both redo CEA and transfemoral. This is a paper that looked at contralateral occlusion. I get asked a lot about that. How does flow reversal work with contralateral occlusion? Apparently it does well because of the PCOM and the posterior circulation. You don't really have to have another carotid. And you see here the outcome is actually better than CEA and better than transfemoral in patient with a contralateral occlusion. And finally, my friend, Dr. Nair, talked about this study here on the right side, but there's another study here with TCAR which shows like we should avoid doing it in the first 48 hours. 3 times more increased risk of asymptomatic patient, 2 to 14 days, probably the best. Mm-hmm. And finally, just a couple of indication, you know, new indication now with TCAR. Maybe when you have carotid aneurysm, it's a good idea with the flow reversal, especially if there's a thrombus, and a lot easier to deploy a cover stent directly through the carotid than transfemoral. This is one of the, 7 years ago, we did this complete occlusion, acute occlusion and stroke, and able to suck the clot. You see the brain on the left before and then after. So it's a good indication, and you see the stuff in the filter. And now there's this ongoing trial that is going to look at TCAR indication in acute stroke with the embolectomy. So in conclusion, ladies and gentlemen, thank you so much again for inviting me. A lot of data. TCAR, I think it's a best of both worlds, a hybrid procedure. So far, much better outcome compared to transfemoral stenting, similar outcome to carotid endarterectomy. All these data that I showed you, they're in higher risk patient. I still believe that a level 1 evidence need to happen. We do need to do randomized trial in normal risk patient and compare this procedure to carotid endarterectomy. Thank you so much for listening.
Thank you very much, Professor Melas. The discussant is Professor Ali Abu-Rama, current president of the SVS and the author of the recently published guidelines of the Society for Vascular Surgery. Dr. Abu-Rama is from Charleston, West Virginia. Ali?
Thank you, Peter, and thank you, Frank and Enrico, and all the organizing committee of this great Carotid Summit. I need to first commend Dr. Melas for all his work in this field. Appreciate all what he have done. The question which I have, which is not clear to me, not only with his presentation, but all the papers published to date about the outcome of TCAR, particularly when comparing it to endarterectomy. I think we need to be very careful for the exact terminology when we say they are comparable to CA, because I'm sure Dr. Melas agree with me, they are not the same type of patient when it comes to anatomy, as you know. We're selectively selecting patients who have a special anatomy, avoiding calcified plaquing and so forth. So my question to Dr. Melas, if we really get the same type of patient anatomy-wise, does he really believe the TCAR have equivalent perioperative outcome to conventional carotid endarterectomy? Thank you again.
Thank you, Ali, for your kind comment. And the answer is I don't know, because everything we've done, like you said, was retrospective analysis, and we compare a high-risk patient getting TCAR to normal risk patient getting carotid endarterectomy. And you do have to have the anatomical criteria that you mentioned to get TCAR, with healthy common carotid and landing zone and whatnot. So I think, really what we do need, and this is what was my very final conclusion in my talk, we do need to have level 1 evidence. We do need to take patients who are similar anatomy and physiology and do a randomized trial before we can make such a statement. But so far, at least in real world data, retrospectively, we've seen similar outcome, even though we're comparing higher risk, patient to normal risk patients.
And with that in mind, Professor Malas, should we use the word in select type of patient, they are equivalent, at least till further notice? Because to me, it can be misleading to junior people who are trying to rush in doing stuff which we don't know the exact answer. Should we say equivalent in select a group of patient or select anatomy? That's what I'm trying to say.
And that's what I said in my conclusion. Ali.
Yes, sir.
Yeah.
Thanks again.
Thank you. Our last presented topic before the panel discussion is on a topic that's really been blossoming in the literature. Carotid interventions improve cognitive function, and it'll be presented by Dr. Wei Zhao, who's really made this work for her recently, I think. She's professor in chief at the Division of Vascular Surgery in Tucson, Arizona, University of Arizona.
Let me unmute myself. Can you see my slide?
Yep.
Okay.
Yes.
Well, this is definitely a controversial topic, and I am really my great pleasure to present it here. So many studies, from population-based study to case-controlled investigations, all have indicated that patients with carotid disease, particularly severe carotid stenosis, affect cognition. One of the latest evidence is from QUEST-2 trial. All of the patients has over 70% asymptomatic carotid stenosis. And the study of the first 1,000 patients showed the same, particularly patient that with the dysfunction in word learning memory test. Now, carotid revascularization procedures is effective in stroke prevention, as we heard today. And many studies have also reported post-stenting, post-carotid revascularization procedure cognitive improvement. Now, there are inconsistent findings, and then many studies have small patient numbers with a short follow-up period. So we leveraged our well-defined cohort of 170 prospectively recruited patients in our NIH-sponsored study. All of the patients had severe occlusive disease who received carotid interventions. This analysis is to determine the effect of the carotid intervention on cognitive function. All of the patients had over 70% asymptomatic or over 50% symptomatic stenosis. Cognitive evaluation was at pre-op, 1 month, 6 months, and 12 months post-op. We use mini mental status exam as gross measurement of cognition. We evaluate their moods with geriatric depression scale, use episodic memory test as a primary outcome measure, and also evaluate executive functions. The cognitive scores were normalized with age and education matched control to generate either scaled scores or Z-score for analysis. Here's the demographics of the population. Half of the patients received carotid endarterectomy, and half of the patients were symptomatic. And all of the patients actually had pretty well managed medically, nearly 90% on statins, and 70% received antiplatelet therapy. We also look at patients who had symptoms of stroke versus those without stroke. Patients with strokes had higher risk of congestive heart failure, had higher incidence of atrial fibrillation, and had higher likelihood to be on anticoagulation. On the contrary, patients who did not have a stroke tend to have more likely to be on antiplatelet therapy, more likely to have peripheral vascular disease. So mini mental status exam is a gross measure of cognition. And the number less than 27 are considered cognitively impaired. At baseline, 38%, nearly 40% of patients were considered cognitively impaired. And that number dropped down about 1/3 after surgery. At 12 months, dropped down to about 1/4. But again, there's no significant statistical significance. So most of our patients also had memory impairment. Word list memory test is our primary outcome measure, VAVLT, as we established here. This, after normalized with age-matched control and also education matched, and our patient's Z-score was less than 0 and nearly 1 standard deviation below 0, below us, so indicating our patient had the significant memory impairment. Now, similar to mini mental status exam, we see high incidence of impairment in memory function. Nearly 75% of patients have a memory impairment. And unlike mini mental status exam, there's significant improvement 1 month after intervention, as well as 6 months after intervention. Here's a box plot depicting the memory changes at 1 month, 6 months, and 12 months. As you can see, there was significant improvement at 1 month and significant improvement at 6 months. 12 months, even though there's no significant improvement compared to pre-op, but they're no worse. Remember, most of our patients had severe carotid disease, has a baseline cognitive impairment. They tend to decline faster, so we anticipate a natural decline in this cohort patients. But in our patient after intervention, there's no significant decline. And on the contrary, it seems even better. And there are several neurocognitive tests used to measure cognition, executive function. One of them is digital span scale test. As you can see, there's a gross improvement here. Even for patients without stroke, even for patients with stroke, there's improvement. And again, there's a box plot to see the compare patient pre and post, and 1 month, 6 months, and 12 months post, there's significant improvement at 6 months and 12 months. Other measures show the similar results, and here shows the different cognitive measures. And for this, the primary improvement was in patients without prior stroke. The language measure, also semantic memory, Boston Linear Test, show similar trends. That occurs both in stroke patient and the patient without stroke. And here are 2 other measures. One is the executive function measure, trail making test. That's the timed measure. The lower the timing, the better the performance. Again, there's improvement in performance. When we look at depression score, patient seems less depressed after surgery, even at 12 months after surgery. Here's the basic but summary table. As you can see across the board, there's improvement, significant improvement by compare individual groups, pre-op to 1 month post-op, and pre-op to 6 months post-op, and pre-op to 12 months post-op. The number in each group are a little different because there is a patient dropout over time. But there's a grossly intrinsic improvement. Even for the depression scale, we did not see significant improvement at 6 months and 12 months, but there's generally trends of improvement in scores. So in conclusion, carotid disease is associated with cognitive impairment, and carotid intervention tend to improve cognitive function measures. There's also general improvement in multiple measures, executive function, although it may not be as consistent as memory. And with that, I thank you for your attention.
Thank you, Dr. Zhao. And for our final burning question from Dr. Athimios Avgerinos, an adjunct professor of surgery in Pittsburgh and a visiting professor of vascular surgery at University of Athens.
Well, thank you for the kind invitation, Dr. Asher and Dr. Glovisky. Dr. Zhao, I think you described very well that carotid disease is definitely not benign and at the minimum contributes to a cognitive decline irrespective of the stroke risk. Now, the ongoing controversy, of course, is whether this cognitive decline can be aborted or reversed through an intervention. And what I got from your talk was a maybe. My burning question is whether you feel we have ways to identify higher risk asymptomatic population for cognitive decline, and also whether CAS, more likely than not, has a less favorable effect on postoperative cognitive function.
Right, so that's a two different question. Thank you for the question. Whether we can tease out the asymptomatic patients that may benefit from intervention in the concept of cognitive function. I think that's an ongoing work. I don't have an answer for you today, but that's a very good question. I'm hoping to be able to give you the answer in the future. I know CREST-2 trials also evaluate cognitive function. So that probably also give you information in a few years. And then as far as the CAS, whether CAS has caused more decline than not. So in our past work, which I have presented and published, we look at microembolization related to carotid interventions. And there's definitely higher incidence of microembolization in CAS patients. And then among those patients with microembolization, patient had higher volume microembolization had a significant decline in memory function. That's almost a linear correlation with the volume of emboli. So as a whole in CAS, I think when we look overall, there's not as good as much of improvement as the CEA patients, but they are not worse compared to baseline. However, those with a large volume microembolization tend to do worse afterwards.
Thank you.
Dr. Brock, did you have a question for?
Not a question, but just a comment in terms of the question posed to Dr. Zhao. The CREST trial has cognitive function testing at baseline and every year, and Dr. Zhao has been cooperating in that regard. And so we will be able to look at cognitive function over time in patients treated, asymptomatic patients treated with CAS or not, and asymptomatic patients treated with endarterectomy or not. In addition, we have 286 patients now who've had carotid perfusion testing, either by MRI, about 3/4 of them, or 25% by CT, and we should have about 400 such patients by the end of the trial. It may be that overall, it comes out that we can't show improvement in one group or another in this randomized comparison of cognitive function. If that's the case, we might be able to show a sweet spot for carotid intervention if patients who have perfusion deficits associated with their carotid stenosis, perhaps those patients might be the best patients in terms of carotid intervention improving cognitive function. So we'll look at everybody, and then we'll look to see if we can find a subset of patients who might benefit from either endarterectomy or stenting.
Thank you very much. Tom, you answered the first question of the panel discussion, and we have a lot of questions that came in online, including several from Melbourne, Australia. But before I do that, I come back to Dr. Veith because he had another question that he wanted to ask, maybe from Dr. Pratt.
Well, Peter, I've forgotten that now, but I have a burning question for Wei Zhu. I think her presentation is really, it's a landmark study, Wei. I congratulate you. But did you do a control group? Because Dave Spence has always preached that in these cognitive testing studies, that patients who repetitively take tests improve in their test taking. So did you take a bunch of patients and just see if they improved, if they didn't have carotid endarterectomy?
Dr. Veith, thanks for the question. I think that's a very good question. So this is all of the patient receive intervention. So we compare them before and after. So they're compared to themselves. Now, whether they're better than the medical management group versus to do whether intervention, whether a surgery, particular surgery is better than others, the control group really have to be a sham control, really have undergo carotid exposure without carotid surgery. And that's almost impossible to do in nowadays. Now, as far as to compare medical therapy, we did not compare medical, but I don't think that's the same cohort of patients for control. And other people, when they look at compared to medical therapy, seems to have looked better. But again, the number are fairly small.
But you don't have to do a sham study. You just take a patient and see if the test that you gave these patients, if people improve with repetitive test taking. That's what Dave Spence always says about all the cognitive studies.
Right. So for the question you talk about is practice effect. So people taking cognitive tests repeatedly, they get better. Now our patient take a test. First of all, the primary outcome measure was a word listing testing test, basically 15 words in the three different cohort words. So they're parallel forms, and then some set their cognitive analysis show that those tests, the specific word listing test with parallel forms, tend to have less practice effect. Now, other tests may have a practice effect. However, the test was taking not frequently. They take a pre-op, 1 month post-op, and then 6 months later and a year later. So they're fairly far apart. And we did see in one of the tests for stroke patients actually did not benefit as well. Didn't remember whether there's practice effect, probably should cut across the board. And in the past, when we look at microembolization, patient with a microemboli did not benefit from the supposedly the practice effect.
Okay.
So we have a lot of questions about this. I think it's on the same topic. Dr. Eckstein?
I see several questions from the panel, but it's 3 o'clock in the morning in Melbourne, Australia. And we have several questions from Professor Abbott. I just would like to start putting up at least a couple of her burning questions because she deserves that, being up and watching this webinar. And the first one is to Professor Allison Holliday. Dr. Abbott says that all strokes should be considered disabling until shown otherwise, and all peri-procedural strokes should be included in treatment comparison and decisions, because maybe the modified ranking scale is not the very best tool to define the severity of the event. What are you saying, Alison?
So we have included the information on all the strokes, first of all, both the procedural and the non-procedural. And if you consider them all to be disabling, well, then the modified Rankin scale is nonsense. It would mean that 0 and 1, which are clearly non-disabling, actually meant nothing. But as I said earlier, in addition to that, we do have patient-assessed abilities from our yearly assessments. So we have got something else to look at, which is very important, and that's the patient's own assessment of any disability as the years go by. And we'll be getting that on average up to 10 years. So some people for a very long time and some people for perhaps just 5 years, but we'll have a lot of more information on that.
And just follow-up question from her. Don't you think that the study was underpowered compared to peri-procedural stroke between endarterectomy and stenting?
Well, we originally actually planned to have more patients, but that wasn't the point. And we aren't actually trying to look at a randomized comparison between that. That's what registries are for. What we are trying to look at is the non-procedural stroke, and that's why the randomized trial is useful for that. And also we did the meta-analysis to look at that in other studies. So I think we've done our very best to address that problem, but I think that we do have to differentiate between the evidence on procedural events and the evidence on follow-up and what happens that you can only get in either a very long-term registry, which doesn't really seem to exist at the moment, or in randomized trials.
Allison, to follow on Ann Abbott's question, I think you ought to ask the families of the minor stroke patients what their changes are, because I know my father had a minor stroke with complete recovery, but he never was the same person. He had changes in his mood and his personality that only we and his family could document. So just ask, he thought he was fine, but he wasn't. So I think you ought to ask the families as well as the patient.
We do get information from the families, but it's not specifically solicited. And as you can imagine, with 3,625 patients, this is not going to be something that you build in at the beginning, but we do have a family member or a friend associated with each patient, as well as their family doctor. So we get different inputs, but actually what the patient says about their own perception is very important, and that annual view of it is important.
That's true, but a minor stroke is not a benign thing, even if there's complete recovery.
Fine, I'm reporting the findings that we have and the fact that according to the scale that's being used, these are non-disabling. I'd like to actually ask a question as well. That's why my hand is up. So I'm in the queue.
Go ahead.
Okay, I'd just like to ask Tom a question. And right at the very, very beginning, he put up the causes of stroke and ischemia and so on. And I think he really said that lacunar stroke was not carotid stroke, and presumably, I don't know that you meant that that's completely true, because it does seem as though some patients with carotid disease in trials where they're randomized and don't have an intervention do have lacunar strokes on the side of stenosis. So it must be quite difficult to actually categorically say that lacunar stroke is not related to a carotid stenosis. That's my question.
As a neurologist, I would agree with you, Allison. The separation is made on the basis of imaging and other clinical characteristics. And what I bet my own savings in differentiating in the setting of carotid stenosis, a small infarct that a neuroradiologist calls a lacume, from something that came from a particle from the carotid plaque or from intervention, I'm not going to take that bet. So I think your point is well taken.
Thank you. Professor Naylor was the next, and Enrico, I'm sorry, then after Ross.
Thanks, Peter. I was just going to point out that our group did a systematic review and published earlier this year on this subject in purely asymptomatic patients. And it's true that cognitive impairment is about 94% of published studies show cognitive impairment. But if you then look at all the evidence for how an asymptomatic stenosis can cause cognitive impairment, there are no compelling studies showing the pathophysiology why, apart from impaired cerebrovascular reserve, which might be an important marker. And then if you look at the effect of carotid surgery or stenting on cognitive function, what you find is after about a year that the vast majority are unchanged. Virtually nobody has improved across all domains, but you have about 25% who have improvement in one or two individual domains. So it's going to be a very difficult subject to prove that intervening on asymptomatic patients improves cognitive function. Because, for example, if you look at the relationship between ipsilateral cortical infarction in asymptomatic patients and cognitive impairment, there are virtually no published studies at all on this subject. And the two that have got completely conflicting results. And I hope Tom might be able to help us with CREST, because they will have a cohort with silent infarctions to look at how that impacts on cognitive impairment, because right now there's virtually no data at all.
Yeah, I have.
After that. Go ahead. Then.
Okay, the question is for Dr. Veith. When you talk about memory loss, maybe I missed in your presentation. You talk about short-term memory loss or long-term memory loss, because they can have some implications, because some of the short memory loss, actually, if you're doing before an operation and the patient is anxious or depressed because he has a carotid disease, his concern is going to have a stroke, that's depression alone, once fixed, say he did the carotid and now the patient is happy as a bird, his memory would already improve because he's no longer depressed or anxious about it. So just questions I had about memory.
Yeah, well, thank you for the question. And also I want to make kind of just follow up on Rash's comment a little bit as well. I most agree with Rash, and also for the memory loss, the most sensitive measure is episodic memory. So basically memory, you have to take time to try to remember and recite. So that's the kind of more of a short-term episodic memory loss. As far as yes, they do feel better. You know, even in our cohort at post-op, 1 month post-op, they have improved their depression scale to significant improvement. But then over time, then at 6 months and 12 months, that kind of come back to the baseline, close to the baseline. Even with that, at 12 months, they had an improvement in multiple cognitive measures. Now, in related to, it's hard to test out, which was Russ' comments. I agree, it's really hard to test out. However, remember this group of patients have baseline cognitive impairment. So you expect them to decline over time, now to stay stable or improvement. If there is the improvement after procedure 12 months prior, I would expect that's improvement may be related to the procedure. Now, I expect them getting worse. I think, in 2 years, they're all have natural trail decline.
Thank you.
Okay, Dr. Eckstein?
Yes. Thank you. I have a question to Mahmoud Malas. Thank you for the talk. And one of your conclusions was that a clinical randomized controlled trial is needed comparing CA and TCAR. So we all know that this will be very, very difficult because of the endpoints. A classical endpoint, stroke and death rate within 30 days might need thousands and thousands of patients to find any difference or to prove non-inferiority. Are there any other endpoints you're thinking of?
Yeah, thank you for asking this important question. We're actually talking to the NIH and StrokeNet about this, but the idea, I think, often we always think, what's better for our patient based on what we think is better. And there's always, every meeting I go to is, people advocate the CEA, they say stroke is the most important. People advocating stent, they say, no, MI is more important. The truth of the matter, there's not all MI is the same, not all stroke are the same, as you can, see from many of the talks today. So I think, doing something like quality of life and cognitive testing, it's very important to kind of get the patient perspective, because if you do a good cognitive testing and quality of life, that's gonna take care of the differences in, you know, how severe the MI is and how severe the stroke is, and how does that impact, you know, the patient. So I think, you know, we ought to start doing this, you know, more often. And I know in CREST-2, we check in cognitive testing. But the other thing is, I mean, we did the sample size and we did look at doing non-inferiority. It's not impossible. It's not impossible. It's, you know, we got up about 800 maybe patient in each arm to do it. So it's not completely impossible to do a randomized trial, as long as we're intelligent about how we look at the outcome and what's important from a patient perspective. Can I ask questions since I had my hands up? Is that okay to? I just want to ask the panelists, and I think the problem of all of this is that we are using the wrong indication for surgery. When we have symptomatic patients, we obviously, it's a lot more straightforward. But all the debate about asymptomatic and all these conflicting data now, and, you know, CREST-2 obviously is going to answer some of that question. But I think, you know, we all seen these patients that comes into the ER with 50% stenosis with a major stroke from their carotid. And we all see patients with 90% that we watch forever for some reason or the other, and they never stroke. So I think, you know, what does the panelists think here about looking more and more into plaque quality? I mean, why are we in the 21st century and we still use a degree of stenosis, which is, you know, from 1970? You know, why aren't we focusing more and more on looking at quality of plaque as an indication for unstable plaque to operate on asymptomatic patients?
We have one final answer by Dr. Brott, who's going to solve this problem in one sentence.
We are using plaque imaging in CREST-2. And a caution is that we're finding plaque hemorrhage in about 30% of the plaques, but we expect events in only 5% of the patients at most. So unless we come up with some other marker in plaques to help us identify and pick out these patients, we're still going to be in the early 21st century in this question.
Well, I think this has been a great discussion. We have a lot of questions that came in online, and I would like to ask the speakers to answer them. And I give back the word to Professor Asher for his closing remarks.
Thank you very much, Peter. This was one of the best webinars we've had. And of course, with this kind of level speakers and discussants, it's just not surprising. I want to thank you all, the moderators, the speakers, the discussants, for being with us, and hopefully we will continue to benefit from the opportunity of inviting you and participating in our future endeavors. I want to finish just with showing you one book here that I think is very interesting. It's called Magic and Medicine, The Extraordinary Journey of a Vascular Surgeon, Peter Klovitsky. So buy it if it's available. Is it available, Peter? Here it is. A great book.
Getting there.
All right. Thank you very much again. Great. Have a great day.
Thank you.
Bye.
Great job.
And thank you, Frank, for being here with us today.
Thank you.
Great.
very much.
Great session.